Alrighty, thank you guys for all coming and sitting through this in-service with me. Appreciate it. But before we get started, I just want to thank all of you for being so good to me, like receiving me with such open arms. Everybody's really giving me so much advice, whether it's from like clinical care or just tips for professional growth and things like that. So thank you so much, everybody. Alrighty. So today's in-service is going to be on Parkinson's disease. This is my first time ever kind of working with Parkinson's patients, so it was really interesting to me to kind of see, what it looked like. I knew nothing about the onset of things and how it happens, what causes it. So I kind of just curious-minded and went about my research, and here we are. So a little bit about the outline for today's presentation. But yeah, we'll just talk about the pathology in itself, see what it looks like, who's at risk for it, what causes it, what the clinical presentation looks like. There's some progressive stages I'll talk about too, and some treatments, which I'll be specifically focusing on the LSVT Big. And then I'll do some review of one of the literatures I found on the LSVT Big and just talk about some of the study limitations, and then we'll be on our way. Alrighty, so Parkinson's disease, it's pathologically defined as a chronic progressive neurodegenerative disorder associated with the loss of dopaminergic neurons in the substantia nigra pars compacta. Really long name, but it's all that's in the basal ganglia in the midbrain. So as you can see up above, it's a little, lighting's not that great, but see all these dark areas here, that's dopamine in the substantia nigra, and on the Parkinson's patients, there's a lack of it. So it's not as pigmented, and in the healthy one, it's pretty prevalent here, and even up at the top on the superior aspect of it. But some key pathological biomarkers of it are the loss of pigmentation and the presence of Lewy bodies in the basal ganglia and throughout the midbrain. So what those look like, some histology is right there. So that's an axon that's just clumped up with a bunch of protein, and it's just kind of spread out throughout the brain. With some of these Parkinson's patients, depending on how progressed they are, it can be pretty bad or it can be just pretty spotty too. So just some quick little anatomy about where we're at. So substantia nigra is at the bottom, kind of at the top of the brainstem, going all around the midbrain, or there at the basal ganglia. So the job of the substantia nigra is to produce dopamine within the basal ganglia. So some of the problems we get there is the low levels of dopamine throughout the system causes a loss of inhibition. So these patients are kind of fighting themselves with unwanted movements all the time. So they lose their precision. Things just get a little harder for them to maneuver and control throughout their daily lives, and sometimes they just keep resting with some tremors and stuff. So what causes this? And to be honest, there's not really an answer. We're still trying to figure it out. Research is still kind of leaning towards like a genetic and an environmental factor, so somewhere right in the middle. So the theory is that the genes kind of start it all and the environment kicks it off. So it's a jump start of whatever you're doing. If you're exposed to some toxins, there's some relations with high or repetitive head injuries, so like in some boxers, and just people who do a lot of just high impact. It's a lot of stuff going on there, but yeah. Anyway, so it's really chronic, age-related disease. So some of the onset is at the later stages in life, but there has been some research that shows that it can start as early as 40, depending on some environmental hazards and some things here. So who's at risk? Unfortunately, it could be any of us. Anybody is pretty at risk for it, depending if you have the genetic blueprint for it. Most of the diagnoses are made around 60 years old, but it varies depending on how masked things are. So they might start pretty low level. You might not even recognize it, and then in a matter of months, they're kind of on a downward spiral there. So the prevalence of PD is pretty high. It's highest in Europe and in North America as well. It might be just due to some of our lifestyles, our diet, The research doesn't really have a direct link to that, but there's a big discussion about toxins and chemicals, pesticides that kind of increase the risk for PD. So some studies spanning across the world have associated that pesticide exposure with like farm work, rural areas, just livestock. And another thing I didn't write on here because I wasn't too sure about it was like well water. So water that just stays on the ground and people don't really like filter it out correctly and stuff like that. So just common things you'd probably see in those like rural areas, farm work. So I listed some of the following like pesticides that were like in discussion of it. I don't know too much about them. So I tried looking at them and they're just kind of everywhere. They're present in a lot of things, even if they're not at a high dose. So I'm going to butcher these for sure, but it's Ratone and Parquat. Those two specifically, researchers have been able to kind of like reproduce like Parkinson systems in laboratory studies and settings. So it's a supporting like plausible reaction or a cause of something that's going on with those two and a few other ones as well. And as I mentioned earlier, some occupational solvents too. So this could be like degreasers, paints, fuels, things around those settings too. Sometimes not the protective PPE that people are wearing when they're using those solvents could be a lead to that, but this is also so unknown so far. So this is the best that we kind of have to educate ourselves. So here's some famous figures and some people who might be in these settings that are at risk. You know, just people that are living their daily life have to get through all their farm work to survive. And then we have our greats like Muhammad Ali, who's passed away now, but he had a pretty big downward progression of Parkinson's. And I put Robin Williams up there because I didn't know he had Parkinson's, but apparently with his autopsy, he was like at the early stages of it. So they kind of found those biomarkers in his brain while they were studying for like his other like depressive behaviors and things like that. So yeah, I mean, we might have it, and we might not even know, but it just depends on. Yeah. So I'm gonna repeat what you said for the recording. So Ken asked if you could have the biomarkers and not have the disorder, and I believe so. So I don't really know. It's one of those things where you don't know to test it unless the symptoms are kind of presenting. So it's like a double-edged sword. Like we can keep screening for it, but it's just kind of hard to figure out like what the patterns are. Because I'm gonna talk about a few like features that might present with these patients. So some of them are not. The basis is mostly motor features, but there's also non-motor features too. So this could be happening prior to the Parkinson's onset or even afterwards. So it just kind of depends how it varies per patient. So it depends what's presented first, what comes after. Sometimes it's the motor, but mostly the clinical diagnosis for sure is based off the motor features. And then some of those features I listed here. So bradykinesia, progressive asymmetric resting tremor, cogwheel rigidity, which in the limbs, the trunk, or the neck, and impaired gait and postural reflex impairments. So in order to be classically diagnosed with Parkinson's, you have to have two of those to fit the diagnoses. And the most important one is the bradykinesia. So if you have that and one of the combos of the others, you'll be diagnosed with Parkinson's. And there's different stages to the diagnosis too. So we'll get into that in a second. But some of the non-motor features that can develop before the motor deficits or even later throughout the disease is like signs of constipation, depression, sleep disorders, cognitive declines, mood swings, and other autonomic changes. So I put this little fact down here. It's based on some of the findings that they've found. So kind of to go back to your question, Ken, the research kind of suggests that like 50 to 70% of the neurons in the substantia nigra have died by the time you have Parkinson's. So it just depends how much is gone and how much like protein buildup is in the brain. So all those protein aggregans just kind of shows like a break through the blood-brain barrier. So things are getting in that aren't really supposed to. But like I said, it's kind of hard. It's kind of hard to see like what comes first, right? Or if you have it before, you're not showing any of these symptoms here. So I put this kind of for myself because I haven't really had too much exposure with Parkinson's patients, and like based off some of the things I was reading, they all kind of present differently. So depending on how progressed or regressed they are, I just kind of stole this mnemonic. It said "Be smart." Found it on on the internet, but it kind of helped me like paint the picture. So the posture is like bent forward, shuffling gait, mask-like face, so kind of droopy, like lack of expression. Akinesia, just slow movement. Rigidity and tremor. So it's kind of listed here on this photo here. And it really depends. Like from what I've read, they might always look like this. They might not. You might not even know someone has Parkinson's until you start talking to them and seeing some of these tremors and some of these behaviors that exhibit. So really interesting. Really interesting. And there's actually a scale and stages to Parkinson's too. So kind of 1 through 5, and it's from regress to progressive, so mild to severe. You guys really can't see that too well, so I'll just kind of read it off to you a little bit. Stage 1 is just unilateral involvement, so maybe just on one side. As you progressed, it's unilateral with axial movement. Stage 2 is bilateral, but no impairment of balance. So this would be maybe like your tremors or just stiffness, rigidity. And then as we progress, independent mobility starts to get more impacted. So some more stooped postures, assistance with just assistive devices. So just definitely more lifestyle modifications that they kind of have to live with until they find something that might help. But usually when they get to these stages 4 and 5, it's really hard to kind of get them to regress. So it's just the nature of the pathology. It just kind of keeps going. Some of the medication, PT, and rehab kind of helps slow the progression, but doesn't really ever go back to where you were. So going on to some of the treatment, I'm just going to talk about medication first, stuff that we might see on our charts. So such as like levodopa or L-dopa. It's considered the most effective and with Parkinson's patients because it does produce these precursors to dopamine, since dopamine itself can't enter the blood vessels of the brain. So it's kind of just replicating that, and once it gets to the brain, it'll start producing that dopamine. One downside of this is that it's not only isolated to the brain, it goes throughout the whole body too. So this might lead you to have those side effects that we mentioned earlier, like constipation, other autonomic changes, mood swings if it's too much or too high of a dosage. So yeah, it's very variable. You know, it's kind of hard to say like a certain amount of medicine or rehab is sufficient for one person, but that's what kind of keeps us on our toes too. Kind of have to work with however the patient presents and what they show us. A few other things were just like dopamine agonists. They kind of do the same thing as L-dopa, but they're lower regressed if there's like some type of allergy to L-dopa or something, they just can't tolerate it. And then in severe cases, they're like a deep brain stimulation, which is a surgery. It's a non-destructive like surgical procedure that involves like implanting a device to help stimulate like the targeted regions of the brain that they want to get. And it's pretty much electric impulses going to the brain. It's battery operated, so it's pretty fancy stuff. So on this little cartoon here, I stole this from my neuroscience course. So it's a little guard here, and it has a hat that says blood-brain barrier, which is the blood vessels of the brain. And it says, hey, we want in. And he's not letting him in because all those heavy particles are just too highly charged, too large, or they're not lipid soluble. So that's dopamine. So it can't really go in as its one form, so you kind of have to find other ways to penetrate those vessels and get the cause of, or the effect of what you want from the drug. Cool. So back to a little bit of clinical presentation now with medication. So depending on if the patient's on medicine or off medicine, they have these things called on time and off times. So on time is when L-DOPA is working well, symptoms are controlled. This is probably when you want to have them move the most, depending on how much they can tolerate for PT, what their goals are, what they want to get out of PT when they come see us. And then there's off times where L-DOPA is no longer working, whether its dosage isn't strong enough, and they're starting to exhibit those symptoms of or their features of tremor, rigidity, slow movement, just really, really, really stiff on those. So as Parkinson's progresses, the on and off swings become more related. So you'll probably get more. It's just like a vicious cycle, unfortunately, as you get to the stage 4 or 5, things like that. So this little picture, I'll just zoom in on you guys. The on and off time should be inverted, but on the on time, they should be a little more control. On the off time, they'll start to sway out a little more. And then these are some of the motor, non-motor symptoms. So if you have fewer non-motor and motor symptoms, you'll have less tremor, less rigidity, more on the other way. So it can vary. It can vary. All right, so the fun stuff. Treatment for PD is PT and all of our rehab partners, OT, SLP. We can use different approaches to kind of work with our patients depending on what's best for them. So we can use attentional control, sensory cueing, just repetitive motions that they want to work on. We can focus on strengthening, range of motion, endurance programs, balance programs. And I'm specifically going to talk about the LSVT Big, because that was something I got to see here with Mike, with one of our patients. So it's pretty fun to get involved with that. And it was actually pretty exhausting too for myself. I was trying to keep up. But a few other popular ones are the Nordic walking regimen and some boxing too. So boxing is just kind of promoting some more motion there, some more force production. And the Nordic walking is actually like a walking program where they're ambulating with 2 sticks. So as they're walking at their pace, they're putting more force through the poles of the sticks to kind of help stimulate more upper extremity control if they don't have the range or the strength to initiate their own range. So more active assistive, I guess, in a way. Recently, when I was getting this presentation together, I learned that a lot of you are actually certified for LSVT Big, which is pretty cool. I didn't even know this was a thing until I got here and I learned about it. So yeah, pretty interesting. It's actually based off of a prior approach for speech pathology. So it's the Lee Silverman voice treatment, where they emphasize a lot of amplitude of voice and just production to get all the amplitude going, get the sensory innervation going. So what they did for the LSVT Big is they combined that with big motions. So there's a couple subsets of exercises that they have, and then there's some more where it's patient specific, where they have their own goals and they do their own things at home. But the big emphasis is to make sure everything's really big, really loud, just to stimulate all that sensory input. So some of the research is kind of really favoring LSVT Big, but it just kind of depends if your patient it's appropriate for them or not. So the goal, as I stated, is just to train them to use bigger movements, and the whole point is for them to practice that in a safe environment and then apply it to their own daily living, so whatever their tasks may be. So there's just here's the schedule for it. It's a big commitment. So sometimes there's a lot of fall off, or patients just don't want to do it because, and even sometimes it's not ideal for us in our outpatient setting. So ideally, what they would like and what the treatment protocol is 4 consecutive days a week for 1-hour sessions at a time. So that's 16 sessions in a month. So that's quite a bit. That's actually a lot. So unfortunately, we don't get to see our patients here 4 times a week for an hour. So a couple things we've been doing, even with Mike and our patients, we work on what we can here, and then we kind of put it on the patient to take ownership of it and kind of carry on with what we're working on here. So yeah, it's a big commitment. Focus on the amplitude, and hopefully our patients buy into it. So there's 7 exercises, about 8 to 10 reps each. I have some pictures of these too. So working on like reaching from the floor to the ceiling, side to side, forward steps, and backward steps, and all these kind of mimic just everyday tasks, whether they're like reaching for the counter, trying to get up from sit to stand, just kind of setting them up to get in those positions that are more comfortable and a little more controlled when they're practicing with us. So there's also functional component tasks. These are patient driven, so it could be anything really. It can be them practicing putting on their jacket, brushing their teeth with their left arm, sit to stand. Usually I do these 5 reps each time they do it. So here are some of the standard exercises. I do have a little demonstration that just pretty quick, but as you can see, the side to side, back, everything.
Let's start with your big posture. Watch Jenny and do what she does.
Sorry guys, I can't get it to go full screen. I'm sorry.
Down to the floor, up to the ceiling, active. And now hold. Hold for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and finish it. You're going to start with your feet apart, and big step and big posture. And once you're there, you're now going to twist across your body with a big movement, and then come back nice and big. Let's see Jenny do that one more time.
Mind your way.
Posture, twist,
You see?
palms
You got it?
up, nice and big, and back big. Reach big, up big, reach back big, and down. Now that you are done with your exercise, remember to use that same effort when you walk and when you participate in your normal daily activities. Wherever your feet take you, we want you to walk with bigger steps and bigger arm swings so that you walk more normally again.
All right, yeah, so one thing I found really interesting is that when we were practicing this with our patient, she just says it felt like really awkward and like she was really exerting herself, but it looked pretty normal. So what their perception of how much effort they're putting is going to vary. So it might even be like they're not even getting the full like arm swing, but they're like, I'm working so hard to get this. So it just a level of perception that they might have, but you just kind of have to keep pushing them for that. That's the whole point of the LSVT Big, is to just keep pushing them to keep reaching those new heights. And it's pretty exhausting too. Each in like the 15 minutes that we do it, she's like pretty short of breath, and we got to give her time to relax. So it's pretty interesting. It's crazy just to see how that connection works and how much like effort she's putting in physically and mentally, it seems like. So some of the standard exercises might not be safe for everybody that you see. So they do have adaptations to it. So you can do some in supine if you just can't get off. It's a fall risk or something. And then they also have seated positions too. And I won't make you guys watch all 5 minutes of this, so we'll speed it up a little bit. Good. And throughout all these exercises, the patient's counting for themselves, and they're really shouting. We're trying to like get them to make it pretty loud, but their shout might be like a normal inside voice at times. So just depends. It varies patient per patient. But we found this one to be really hard with our patient, just because she just didn't feel comfortable with that rotational movement. So you can combo them. It just depends on however your patient's presenting, whatever's safer for them. But yeah, loud voices, big movements, big slams. I know, right? It's yeah, it's pretty hard. It's pretty hard. Even myself, like when I was trying to do it, I was like going the wrong way and stuff, trying to play it off, but it worked. It worked out. Alrighty, and then just to kind of wrap up on some of these things that I already mentioned in the video. So some hierarchy tasks. These are considered the long-term goals in the LSVT Big. So you kind of progress them throughout the 4 weeks that you're with them. Whether it's getting in and out of bed or like mimicking a golf swing. Like if you're starting with this rotational movement, maybe have them out here, just progress it as you need to. And then of course the big walk. This should be like integrated at the end of like every session, as stated per LSVT Big, just to emphasize that normal gait pattern that they're trying to get to and that we're trying to promote with them. So some big takeaways, just really high effort, high amplitude, repetitive, resistance to whatever they can tolerate, and then more importantly, accuracy in the movements that they're trying to do since it's all new for them, and just watch the fatigue. And some of the researchers say that like intensive practice is important to drive maximal plasticity in the brain. So complexity matters and repetition matters. So if the long-term goals seem too easy, then keep them on their toes. Cool. So I found this one study specifically that I wanted to talk about, just comparing some exercise prescriptions and methods for Parkinson's disease. The purpose was to compare the effects of the LSVT Big, the Nordic walking program, and just like a unassisted home exercise program. So it was a randomized controlled trial, just comparing LSVT Big with those other two active interventions. So this study had 60 patients, and they were all randomly assigned to either the LSVT Big, the Nordic Walk program, or the domestic home exercise program. So it was just off of drawing. So mobility levels didn't matter, just whatever they drew. So the inclusion criteria, you had to be referred by a local outpatient clinic or an office-based physician. The Parkinson's had to be idiopathic with a Hohen and Yahr stage of 1 through 3. So still able to ambulate, still able to move, still able to exercise. And you had to be on stable medication 4 weeks prior. And some exclusions were if you had episodes of severe depression, dementia, or comorbidities that didn't let you exercise or just effective mobility, you weren't able to participate in the study. So for the methods, patients in all the groups received the same amount of time with each therapist. So whether it was the LSVT Big or the other two groups, they all had 1 hour sessions with them. So one physical therapist was certified with LSVT Big and the Nordic walking instruction. So they did all three groups. So they spent 1 hour, and they kind of just followed the protocol for LSVT Big, like 16 1-hour sessions 4 times a week. And then they followed the standard protocol for the Nordic walking thing. So 16 sessions, 2 times a week for 8 weeks. And the Nordic included like a warm-up, walking, and a cool-down. So it was just kind of comparing the two as close as they could to whatever was a standard protocol. And then the home group, they just got one hour of instructional exercises, whether it's on range of motion, muscular power, posture, functional activities. And then some of the outcome measures they used were the Unified Parkinson's Disease Rating Scale, Part 3 specifically, which assessed the motor signs of Parkinson's disease. So this would be kind of starting with the baseline of like finger tapping, hand movements, pronation, supination, to just see if there's tremors, rigidity, things like that, and see how much they could do in the time that they had. And then quality of life before and after, timed up and go. the 10-meter walk test, and all these tests and everything that they were doing throughout the study had to be done while the patients were on the on phase of their medication. Cool. So I've never actually seen most of these besides the timed up and go and the 10-meter walk test. So like the Parkinson's disease questionnaire and the disease rating scale. So this is a little close-up of the disease rating scale. So they would just look at facial expression for 10 seconds and see if it was normal, if they started drooping, finger tapping. So they all kind of had their criteria of what to rate them at. And then the questionnaire of the quality of life just included questions like how difficult are things at home, all the way to avoided situations where you don't feel safe going out. And then, of course, the depression. So if the episodes were, if there was a higher risk for depression, they'd take them out of the study if possible. So some of the results, 60 patients started initially, 58 made it all the way through, so ideally 20 in each. No dropouts in the LSVT Big. One withdrew from the walking protocol just due to consent, and one from the home exercise program due to psychosis. So some of the results here, based on the outcome scores, it's a pretty big change in the motor scores from the LSVT Big compared to the other ones. So there's a pretty stagnant line down here for the LSVT Big, and the other ones didn't do much for those motor assessments. They did some changes for like the quality of life and some of the other outcome measures, but specifically this study went to see what LSVT Big would do for the motor performance. And here's some grids that kind of compared the before and after. So I'll just talk about the LSVT Big scores, and then I'll just maybe make my way down to the walking. So a little bit here. So baseline. So those are just the difference of like a 5 standard deviation, which is what we saw in that dip going down on the motor scale, compared to like some of the walking protocols where it was only like 0.58 and a 0.1 on the home program right here. And then some of the quality of life scores, the LSVT Big didn't score too high on some of those questionnaires. It did show some improvement on the tug, a little more than it did on the walking and on the home exercise program. And same thing with the timed 10-meter walk test. So just some more improvements on the LSVT Big compared to the 59, the 45. LSVTQ got a 1.12 standard deviation there. So unfortunately, no major impacts on the motor changes with the Nordic walking training protocol or the home exercise protocol based on some of the findings of the Parkinson's scale there. And some more results. I just wanted to point out that there was really no significant differences between the age groups throughout and their duration of the disease. So it was kind of a small mean. They were mostly in their 60s, all around like the 2 to 3 stage of Parkinson's, and some of them had like a mean age of like 7 years of how long they've had Parkinson's. Cool. So the blinded study just had a degree of change. Kind of talked about this already, but it was like a 5.05 degree of difference, significantly favoring the LSVTQ over the other two protocols. Some of the outcome scores, as we mentioned, the tug, the 10-meter walk test, I kind of focused in on those, even though they were mostly addressing the motor performance, just because those are things I've seen here, like the tug and things like that. So I'm curious to see like if our own patient would exhibit the same things with like the tug and things like that. No significant changes in the questionnaire, the quality of life, stayed about the same. And then authors conclude the differences between the studies favor the intensive one-on-one training protocol of the LSVTQ Big. And yeah, there's just a little superior in this setting to the Nordic. So I did want to point out some of the study limitations. So some of maybe the home exercise activities were varied between patients. Maybe some put more effort than others. The LSVTQ Big kind of emphasizes more patient ownership. So such as like the hierarchy goals, the functional task goals, those are things that are kind of integrated within the LSVTQ Big that aren't integrated within the other two. So it kind of just reminds them to keep themselves going, and it's easier to kind of veer off of like the Nordic walking trail, the walking protocol, or just a regular home exercise program. And something that might have skewed some results too is that there were adjustments in medications for 3 subjects. So it could have been like a decrease in L-DOPA, and they just weren't doing that well, so it might have skewed the results. And then environmental factors too. So it's a big difference when they're in the clinic in a safe environment versus doing all the home exercise program that the home group had to do. It's just more confidence, better equipment, gait belts, things like that. And then last but not least, I think further studies need to evaluate whether the LSVTQ Big can cause permanent changes throughout like long term, like 2 years from now, or if the studies are just happening while they're doing it, just to really see if it can drive some neuroplastic changes. These are some of the references I quoted. Any questions? Yeah. So that's the standard protocol. That's what they would like to do, but it's not really feasible sometimes, depending on like insurance or how much time you can get with your patient. But usually it's 4 sessions a week, an hour at a time.
Hey Kevin, so let's say I would bring my dad to you, right? You were trying to sell me on this program. Not Parkinson's, early stage.
Mm-hmm.
If we see the next 6 days, what do we do?
Yeah. So according to some of the research and the findings of the LSVTQ Big is just easier initiation of motion, kind of being able to get to those positions more comfortably, safer, and progress you throughout those 6 weeks. So throughout that month, we would want to see like those changes in gait, like the arm swing, normalizing the stride length, meeting your goals, whatever those goals were too. So if you're able to put your jacket on sooner, you're able to get in and out of the car faster, things that keep you safe at home. So those are things I would kind of focus on, especially for those LSVTQ Bigs, is the safety of like motion, whether it's from sit to stand, the goals of the patient, and just seeing if everyday activities are a little easier for you too. So we're doing twice for 30. Yeah, so we just kind of modify what we can. And luckily our patient's pretty good about like doing her part too. She's actually pretty excited about it. And it's really interesting to see like how her mood changes throughout the 30 minutes we see her too. So she kind of just has some more pep in her step when she leaves, if that makes sense. She's a little more alert. But yeah, it's pretty fun for her too. So I think that's always a good thing as well. So yeah.
So I want to piggyback off that question.
Mm-hmm.
Is there like taking into consideration like clinical equipoise? Is there just as much change in 30 minutes that there would be with a full hour or 4 times?
Yeah. Yeah. I did look at a study. I didn't list it on here because it wasn't the best setup of the study, anyways. But they were comparing like the standard protocol versus like a 2 per day protocol, and they kind of had the same results, which was a little up in there. That's why I didn't really include it in the presentation. But I think just you'll probably have the same results, just at a lower degree, depending on whatever you can do with your patient. But yeah.
I heard talking from therapists with patients. They said that they don't stay with the program. Is there like number one reason why?
Yeah, probably just how intensive it is and how much work it is. It takes quite a bit of time. All those 8 exercises, the goal is to do it continuous without a break. So maybe take a rest break and go on to the next one, do some more and go on to the next one. So
like you were saying, like they're doing big movement, right?
Yeah.
So, but their perception is that it's so great to them, but they need to be that safe to them, or for their own phone, but it's in
Yeah, actually, yeah, that's a really good idea. I think that would be yeah, it'd be a good way for them to visualize what they're doing too. But yeah, no, I agree. That's actually a really good idea. Cool. Alrighty, thank you guys. Appreciate it.